Thank you. Good evening to everybody. Human papillomavirus infection is one of the most common sexually transmitted infections worldwide and plays a very important role in the pathogenesis of anogenital cancer. The vast majority of HPV infections in immunocompetent individuals is transient, but this is in contrast to immunosuppressed subjects such as HIV-infected individuals that exhibit higher prevalence and incidence of oncogenic HPV types and squamous intraepithelial lesions of the cervix, vulva, and anus compared to the general uninfected population. The incidence of invasive cervical cancer is also higher in HIV-infected women, as well as that of anal cancer in HIV-infected women and men. Treatment with antiretroviral therapy has the potential to alter the natural history of HPV infections. However, the impact of ART is still debated, and while some studies showed clear reductions in progression of lesions or disease, others have shown that there is no positive immediate effect of ART on HPV infection, incidence, and clearance. Thus, vaccination really represents the primary approach to prevent HPV infection. 2 vaccines have been licensed for use in women aged 9 to 26 years, a bivalent vaccine against HPV types 16-18 and the quadrivalent vaccine against HPV types 6-11, 16, and 18. The latter has been recommended also for men aged 11 to 21 years. Both vaccines have demonstrated effectiveness against HPV infection and also the development of precancerous genital lesions in both women and men. And currently, the American Council of Immunization Practices recommends HPV vaccination also for HIV-infected individuals, both males and females, aged 11 to 26 years, regardless of the HIV status or the CD40 cell count. Although there are few efficacy data on HPV vaccination in HIV-infected populations, this recommendation is based on very recent researches that showed how the quadrivalent HPV vaccine was safe and immunogenic in HIV-infected children, women, and men. However, further data are needed on immunogenicity of HPV vaccines in HIV-infected adolescents, focusing on both arms of the immune responses, so both humoral and cell-mediated immune responses to the vaccine, in order to further inform recommendations for vaccination in these individuals. To this aim, we designed a study to characterize the immune response generated by the quadrivalent HPV vaccine in our treated HIV-infected adolescents and young adults, and in sex and age-matched uninfected individuals that were enrolled in an 18-month prospective non-randomized controlled clinical trial. Study subjects were 47 perinatally HIV-infected individuals, both females and males, clinically asymptomatic on ART with an effective CD40 cell recovery and good compliance to the therapy, and at least 2 suppressed viral load during the 6 months prior to enrollment. 47 HIV-uninfected healthy controls, comparable for gender and age, were recruited as a control group, and each subject received the quadrivalent HPV vaccine at baseline after 2 months and 6 months after the first vaccine dose. Vaccine immunogenicity was assessed by evaluation of total HPV-specific IgG antibody titers in serum samples collected at baseline and 1 month after each vaccine dose up to 18 months. Cell-mediated immunity to the vaccine was characterized by analyzing T-cell patterns in blood samples collected at baseline and 1 month after the second vaccine dose at month 3 and the third vaccine dose at month 7. At the same time frames, cytokine production and CTL activity were evaluated in peripheral blood mononuclear cell cultures restimulated in vitro with recombinant HPV vaccine type 1 proteins. Longitudinal monitoring of CD40 cell count and viral load was assessed at enrollment 1 month after each vaccine dose up to 18 months from baseline, and a safety profile was assessed by determination of signs and symptoms in all study participants for 30 minutes after each vaccine administration. Total HPV-specific IgG antibody titers raised shortly after the second vaccine dose at month 3, peaked after the third vaccine dose at month 7, and rapidly decayed within 12 months, with a further slower decrease up to 18 months following baseline, those reaching their seed state value, both in HIV-infected and uninfected subjects. And while the antibody levels mounted as a response to the vaccine were somewhat lower in HIV-infected children, antibody titers were quite robust, and all participants among HIV-infected individuals experienced a seroconversion at month 7. Since chronic antigenic exposure to HIV-1 alters the memory-naive subsets of T cells, we analyzed T cell patterns in response to vaccination. Administration of the quadrivalent HPV vaccine drove the relative proportion of T cells and led to the preferential expansion of naive and central memory CD4 and CD8 T cells, both in HIV-infected and uninfected individuals at month 3, with subsequent activation and differentiation in effector memory and terminally differentiated T cells at month 7 in both study groups, with no significant differences between HIV-infected and uninfected individuals. According to the lineage relationship between the subsets that proceeds from naive to effector memory in TD cells through the central memory intermediate. Further analysis of T cell activation markers showed an increase compared to baseline values in the frequency of CD25 positive, both CD4 and CD8 T cells at months 3 and 7 in both HIV-infected and uninfected individuals. Similarly, the percentage of CD25 positive, HLA-DR2 positive CD4 cells and CD825 positive HLA-DR2 positive CD8 T cells significantly increased from baseline at months 3 and 7 in both study groups. But this time, the percentage of activated CD4 and CD8 T cells was higher in HIV-infected individuals compared to healthy controls. However, no significant changes in the expression of CD38 on CD8 T cells was observed among HIV-infected participants. Cell-mediated immune responses were higher at month 3, so after the second vaccine dose, in which we just observed a higher frequency of L1-specific IL-2 secreting CD4 T cells and interferon gamma secreting CD4 T cells in both study groups, with no particular significance between HIV-infected individuals and uninfected individuals. The only thing that we observed was a slight decay in the percentage of IL-2 secreting CD4 T cells at month 7, while interferon gamma secreting T cells remain stable up to month 7. Similar results were observed looking at the percentage of HPV-specific interferon gamma secreting CD8 T cells that increased from baseline up to 7 months following the first vaccine dose. And analysis of cranial-dependent and independent effector mechanism of CD8 T cells showed an increased production of TNF-alpha, perforin, and granzyme beta at month 3 in both HIV-infected and uninfected individuals, while the production of TNF-alpha remains stable up to month 7 in both study groups. Secretion of perforin and granzyme beta increased over time up to month 7 in both study groups, with no significant differences. CD4 T cell count among HIV-infected individuals remains stable from baseline up to 18 months following the first vaccine dose, as well as the percentage of CD4 T cells that showed a slight but not significant increase over time. And most importantly, the majority of patients remain with undetectable viremia up to 18 months following the first vaccine dose. The quadrivalent HPV vaccine was generally safe and well tolerated, and the most common adverse events were injection site reactions and self-limited mild systemic symptoms that were reported in both study groups with no significant differences. No severe or life-threatening adverse events were reported in all vaccines. So, in conclusion, the standard 3-dose quadrivalent HPV vaccine regimen generated antibody responses against HPV types that last for at least 18 months in HIV-infected adolescents are treated, and in sex and age-matched uninfected healthy controls. The quadrivalent HPV vaccine was able to induce functional activation of the T-cell compartment and led to a robust cell-mediated immunity that was characterized by production of Th type 1 cytokines and also CTL activities from baseline up to 7 months following the first vaccine dose. This study is still in progress to determine the persistence of cell-mediated immunity to the vaccine up to 18 months from baseline. No adverse effects on the markers that are traditionally associated with HIV-induced loss of immune competence were reported among HIV-infected individuals for the duration of the study. And the quadrivalent vaccine was generally safe and well tolerated. But most importantly, among HIV-infected individuals, the magnitude of the cell-mediated immune responses was completely comparable to that observed in uninfected individuals, suggesting that this arm of the immune system is not impaired, at least in the context of an apparently satisfactory immunovirologic response to antiretroviral therapy. And these results further recommends vaccination in these individuals. Thank you for the attention.